There will also be a short survey at the end for you to share your thoughts. So at this time, I'd like to introduce Dr. Ravi Bukkapatnam.
Thank you, Julie, for that introduction, and welcome everybody to this information session about some of the latest and greatest in treatment options for overactive bladder and retention and fecal incontinence. And we'll go through some of the details about the disease state, and then we'll talk a little bit about what are the options as far as medical therapies, and then of course on to advanced therapies as well, which we're very passionate about and have been doing this for a long time, and we've really changed patients' lives over the last 2 decades with this therapy. And so I hope my passion for both the disease state and for the treatment options that exist comes across to you all. With that, let's go ahead and start talking about overactive bladder and some of the other conditions for which we have these exciting treatment options for. So many people don't appreciate or know how common overactive bladder is and how significant an impact bladder control problems can lead to patients' lives. Nearly a third of Americans have overactive bladder. And so it's very common. About 30-something million people, 37 million people in the US suffer from overactive bladder. And it leads to not only obviously the signs and symptoms of overactive bladder, but can really have far-reaching effects on one's life, including quality of life and even quantity of life, really. The most common reason for admission into a nursing home later on in life is because of incontinence. And so it really is a significant impact on patients. You see here some of the things that overactive bladder can lead to, including loss of sleep, loss of confidence, poor feelings about general health, etc. But all of these ultimately will have secondary health effects. Loss of sleep can truly affect one's functioning life, and so it really is something that shouldn't be minimized, both by healthcare providers and of course by patients as well. And so really something that should be treated. Let me go back one slide for a moment and talk about what else the lay of the talk today will be. So we'll talk about bladder control. We'll go through the care pathways that we exist. And when we say care pathways, it's a plan for a patient to know how their specific disease state will be addressed. But it's really more than that. These are evidence-based protocols that have been shown to impact what we just talked about. So this is literature-based, it's evidence-based, and ultimately leads to better life, better quality of life, better quantity of life even. So we'll talk about that. We'll talk about the treatment options that I just mentioned. We'll talk specifically about InterStim, which is a great treatment modality for overactive bladder. And we'll also talk about the neurosystem as well, which is an office-based therapy that also can help for those patients who suffer from overactive bladder. So let's go ahead and look at the slides for what overactive bladder is and how do we diagnose it, what are the symptoms that are involved. So by definition, overactive bladder is when someone voids more than 8 times a day. So if you really are critical about it and you count how many times you void in a day, anything more than 8 is defined as overactive bladder by the International Continence Society. So this is a definition. Urgency is also associated with overactive bladder, and urgency is basically that feeling where you have to go right now, that sense of impending doom, otherwise you might lose urine kind of feeling. How does this impact patients? Patients will have this feeling that they have to go right now, and it impacts when they leave the house. It impacts how they drive from point A to point B. I have patients that tell me that they know where every rest stop is along the way. They know where every shopping center is because they know they'll have to stop somewhere to look for a bathroom. It leads people to drink less. It makes them make sure that they don't drink so that they can participate in social activities. And ultimately, a portion of these patients will have incontinence. So they wear undergarments, pads to protect themselves from leakage. And you may have heard that industry is actually one of the largest industries. It's a multi-billion-dollar industry selling undergarments, depends, pads, etc. So unfortunately, these patients are suffering in silence, and it's something that we have a good solution for. Now, when we think about bladder control, oftentimes we think that it's a very simple process, and the whole voiding and continence process is actually a rather complex event that we all take for granted. So when the bladder fills with water, the kidneys make the water and they put it in, they secrete it into the bladder. And the sole function of the bladder is to hold urine until you tell it to become activated at a socially convenient, acceptable place. And that occurs by the brain sending signals to the bladder to stay silent during filling, and then to activate when you tell it to. And so there are nerves that go to the bladder that tell it to contract. There are nerves that go to the bladder that tell it not to contract. And there's sensory inputs that go back to the bladder, telling the brain what the state of fill is in the bladder. And so when there's any misbalance in all of these neural connections, something pathological happens. So you may get sudden urgency, you may get frequency, you may get incontinence. So it's these nerves that are the control center, the control system behind normal continence, and that any disorder in this communication pathway will lead to the disease states that we just talked about. It's not the job of the kidneys for continence, it's really the bladder only. And the same thing actually exists for bowel as well. So the same nerve pathways exist, they travel through the same fibers. And so any mishap in that nerve communication can also lead to fecal incontinence or loss of stool. So at a much higher level, what causes incontinence? It's a long list. One thing that's not on this list, which is rather obvious, is the aging process. So as we age, we do develop a certain proportion of incontinence and frequency and urgency, but it's not necessarily normal because there are things that we can do to fix it, and there are medications, and there are behavioral modifications, and ultimately, of course, neuromodulation or InterStim, which will address it. But besides the aging process, daily habits, what you drink. If you're drinking 6 Diet Cokes in the morning, well, that'll exacerbate these kind of things. Medications can cause this. If you have reduced mobility, it can lead to incontinence. It's amazing when we see patients and they have a reduction in their mobility. Just 30 seconds can make the difference between making it to the toilet and not. And so that has a big part. And then, of course, finally, pregnancy, childbirth, radiation therapy, pelvic floor injury, all of these can lead to incontinence. Now, that last bullet makes one sometimes, and physicians are absolutely guilty of this as well, to think of this as a disease state that affects only females, and it's absolutely not the case. If you look at longitudinal studies and look at the difference between the sexes, men and women are equally prone to getting this condition. So it's really our job to educate patients to understand that we have to treat men and women to consider this disease state as a possibility. Now, when we look at bladder control problems, there's really 3 broad categories of bladder control problems. The first is stress incontinence, the second is retention, and the third is overactive bladder. It's these latter 2, number 2 and number 3, that we'll specifically talk about. Now, stress incontinence is leakage when you cough and sneeze and laugh and jump, any activity that creates a rise in the pressure inside the abdomen and the bladder that pushes the water out. So it's truly an anatomic defect of the urethra with lack of support that can cause stress incontinence. And there are a separate set of treatment options for that. But there are treatment options for that as well, which we utilize very commonly. things like bulking agents, things like slings, things like pelvic floor therapy. All these things do make a difference for stress incontinence. And so there are treatment options for that as well. Now, moving on to the other items that I mentioned. So urinary retention, or the inability to void, or the inability to empty your bladder, is also a common condition that we see. And it's because of that nerve input that we just talked about a couple minutes ago. Anything that goes wrong in that system that prevents or doesn't allow the bladder to send the appropriate signals for the bladder to contract can lead to urinary retention. So these patients, unfortunately, end up having to use catheters, tubes inserted into the bladder to address this. And pacemaker therapy, interstim therapy, neuromodulation, all sort of the same thing, can help with retention as well. And then finally, we talked about the third type of urinary dysfunction, which is overactive bladder, that broad category that includes frequency, that includes urgency, so voiding more than 8 times a day, that sudden urge to go, and then ultimately urge incontinence, not making it to the toilet in time before the bladder starts to push the water out. So urge incontinence, again, is going to the toilet or not making it to the toilet in time when you feel the urge to void, and then having leakage or incontinence. And these are the patients that typically will use some sort of protective wear to address that. And then frequency and urgency, like we talked about. So in the same realm, fecal incontinence also does very significantly impact patients' life. They leak stool, they have a sudden urge to have a bowel movement, and they can't make it to the toilet in time. It's very disabling, and really impacts patients' perception of themselves, of their health, their physical and psychological well-being. It can lead to skin breakdown. It can lead to infections, etc. So all of these conditions are something that we really should pay attention to. Well, you know, many of these patients suffer in silence. I can tell you that when we talk about overactive bladder or fecal incontinence, and we talk about the fact that there's 38 million Americans suffering from this, we do a terrible job. We, being the medical community, does a terrible job of bringing this up and of providing treatment. And it's the job of people like me to go out and scream from the mountaintop to tell patients that this is something that we have a way to treat to make you better. So how do we go about this? What do we do? Well, the first step is really to diagnose it, to talk about it, to meet with your physician, to meet with your healthcare provider and say, I have a problem. And so the first step is diagnosis. Now, once that hurdle is reached, then we can launch into these different treatment options. There are very simple things that one can do. Lifestyle changes, what you're drinking, what you're eating. Bladder irritants are something that we try to cut out. And it does help. Moving on, there are medications that can help patients. In the past, a lot of these medications came with side effects, significant side effects like dry eyes, dry mouth, constipation, etc. And so patients oftentimes stopped taking their medications. And then finally, when medications fail, and they do fail, then there's options that can help. So oral medications, like I mentioned, come in 2 classes, anticholinergics and beta-3 agonists. I know I'm getting very detailed, but these are important words that I think that you should know about. And so medications have gotten better, but they still do have side effects. The problem with medications in general is that people live their life and they have a hard time remembering it. If it's not controlling your diabetes, oftentimes we forget about it, we don't take it. And so when that happens, you're back in the same boat. You know, looking at the bottom of that slide there, you see after 6 months or so, the vast majority of patients actually quit taking their medications. A large part of this, some of you who are listening may have tried them. The cost of these medications is not cheap, unfortunately. It imposes a significant financial burden. And so this is unfortunately the first medication that gets dropped off. And while that's unfortunate, that ultimately leads to treatment failure either way. So what can we do for patients who go down that pathway and unfortunately quit the medication. So there are procedures that one can offer to these patients. You may have heard about Botox injections to the bladder. Botox is the same Botox that we use cosmetically. Not me, of course, I'm too young for that. But Botox is an option for this. And it basically is injected into the bladder through a camera, and it helps with frequency, it helps with urgency, it helps with urgent continence. It's very successful. The problem is it's a procedure, and the problem with a procedure for Botox is that you have to repeat it every 6 months or so. So it is onerous for both patients and physicians to continuously do this. And again, you'll see the number at the bottom there. We said 74% of patients will quit medicine. Well, about half of patients will stop taking Botox after a year or so. And so again, it works in the period of time that it's done, but then it fails. So it's again something that's repetitive, and you have to keep remaining dedicated to it. So with this problem of not staying on therapy, this is how these advanced modalities ultimately were developed. And when I say ultimately were developed, this came around when I started my career some years ago, in the late 90s, when neuromodulation, InterStim specifically, really broke the ground and created a pathway to address bladder control and then ultimately bowel control as well. And the Medtronic InterStim system, which we've been implanting for that long, it's actually been around since the late 90s, has changed people's lives. It has changed their bowel and bladder habits so that they can live it. I still have patients that I've seen for 20 years that have successful implants that still function for them. So it's really revolutionized how patients live with their overactive bladder and how successful it can be. So the InterStim is an excellent option that helps with both bladder and bowel control. Now, it's an implantable device, and the neurosystem that you'll see here is a non-implantable device that we stimulate the nerve behind the ankle. And that nerve actually connects to the same nerve in the slide that you saw, where you saw the pictures of the nerves between the bowel and the bladder. So stimulating the nerve at this site can also help. So it does work. Unfortunately, with this system, it does require repeated treatments, and we do offer this in our office as well. And it's a simple 30-minute procedure process with a tiny little needle that's like an acupuncture needle that you can barely feel, that goes into that area of that nerve. And for 30 minutes, we stimulate it, but it's done for 12 weeks, once a week for 12 weeks. And we actually can do it as maintenance for a longer period of time, and these patients do have success. But it does, like I said, require that level of commitment, requiring 12 weeks of in-office sessions, 30 minutes at a time. It's a good option. It's improved patients' lives, but requires that dedication. Obviously, what can we do for patients for those who want to say, I want to be better now, and I really don't want to have to deal with this coming into an office, coming into a physician's office over and over for treatment options? Well, this is where sacral neuromodulation really has changed the game for physicians who offer it and for patients who receive it. And you see a small picture there of the different sorts of pacemakers that we have. And I've been privileged really to see the development of these pacemakers over the last 2 decades, and how the technology itself has reached what we have today, which is a very highly advanced pacemaker control therapy system for both bowel and bladder function. And the picture on the right side with the 2 different implants there, one is a non-rechargeable device, the other one is a rechargeable device. The smaller one that looks like a small USB drive is a rechargeable technology, and the one on the left side is the non-rechargeable device. Even only in the last year or 2, we've seen improvement in this technology where the non-rechargeable device can last up to 15 years. So we implant this once and we've changed that patient's life for that period of time. Very remarkable, the kind of success we can offer to a patient with this kind of technology. And like I said, the technological improvements that have happened in front of our eyes are equally remarkable. When we started putting them in, they were a little bit bulkier. They didn't last as long. They weren't necessarily MRI safe. Today, Medtronic has paved the way for MRI safety, has paved the way for devices that have long lives, leading patients to forget about this condition and live their lives the way they want to live it. So how do we embark on this process? Where do we start? Well, like we talked about already, the first step is diagnosis. The first step is going through the different treatment options. And ultimately, if you fall into the category of wanting something more, this launches the process. The first step is a simple test done with really under local anesthesia, where we place these tiny wires that are a little thicker than a few hairs alongside the nerves that control the bladder in the low back. It's not back surgery, it's not neurosurgery. These are peripheral nerves that have exited the spinal cord, that have really gone away from anything critical. Simple test with 2 wires placed there, and usually in the first 3 days or so, it's like a light switch. It changes once voiding patterns. It addresses these symptoms, and we'll do the test. We see the patient back in 3 days typically, and by that point, those patients will report significant benefit over their bladder symptoms. It's not unusual for me to see patients who come back after the test and say they don't want to get rid of the test wires because they're so happy how they're done in just a matter of 3 days. I hear patients tell me it's the first time they've had a full night's sleep in years. It's remarkable how quickly we can change patients' lives with a simple test. Now, once we do that test, that launches the second phase where the implantation is done. Again, a very simple outpatient procedure that is done through a very small incision, and that pacemaker that you saw is inserted into the buttock area and starts functioning. That small device is not felt through the clothing, it's not seen from the outside, and has a long life like we talked about, is MRI compatible like we talked about. So it's I'll hold it up for you so you can see it. And again, it's very small. I'm holding it in my finger so you can judge from, I don't have big hands, so you can judge. It's basically the size of the tip of my fingertip here, and it's very thin as well. Now, with that, how do we do? How well do we do? Well, the literature suggests that over 80%, over 85% of patients will have satisfaction with their bladder symptoms once it's implanted. We typically see greater than 75 to 80% of improvement in these patients. And the other part that you see here, is that you don't see here rather, is that it is long lasting. The majority of patients, the vast majority of patients have long lasting durable results beyond the decade mark. And when we look at strict criteria and look at studies that have compared how patients do with neuromodulation, with InterStim, compared to those who take medications, there's a big difference between the success that we see with medications and the success that we see with InterStim. And it gives patients back their life. Their frequency gets better. They void less than 8 times per day. Their urgency is resolved. Their leakage stops. Their fecal incontinence gets better. Their retention gets addressed as well. So highly efficacious, highly successful, very well tolerated treatment option for overactive bladder, for retention, and for fecal incontinence. So I'm passionate about it because we are able to change patients' lives. We are able to offer them a therapy that unfortunately they haven't had the chance to know about, to hear about. So it's exciting for me to talk about this in a forum like this. And I'm always obviously happy to help patients who would be wanting to talk about their bladder and what treatment options they have for addressing their issues. My contact information is there, and we're absolutely happy anytime if you're interested to go over this. So with that, I hope that my passion for this disease state comes across. I hope that you have picked up on the treatment options that exist for this disease state, for this condition, and the fact that we really have some very good options to offer in this modern day for this. So with that, I'll open it up to questions, and hopefully I can answer them.
Thanks so much, Dr. B, for the presentation and for your time. If anybody has questions, please click on the Q&A that's likely at the bottom of your screen and type it in and we'll answer it. So Dr. B, a question has come in, and then there were some that came in earlier as well. But for a participant in tonight, he's asking a question. I have recently was on a trip where my bladder let me know I had to go, but I never felt it when it was going until it hit my pants.
So this is exactly the definition of urge incontinence. So sudden urge, may not even be noticed, that urge. And then the first thing that we notice is that urge incontinence. It does fall under the category of overactive bladder. And that sort of patient is the ideal candidate, really, for this sort of treatment option.
Next question is, I visited another urologist and I've gone through a bunch of protocol. The meds did not work. Would I have to start all over again, or can you get my record from my previous doctor so I can move on?
So we typically utilize what information we have, as long as that information is good and it's, you know, readable and interpretable, and we're able to utilize what has already existed. So in my practice, as an example, if that patient has already tried 2 medications, as an example, they have classic overactive bladder symptoms, I'm not going to restart the whole process again and go through another set of medications. We would truly start talking about this treatment option as the potential next step to address it.
Next question is, does insurance cover the procedure?
Absolutely. This is FDA approved. This is approved by insurances. This is reimbursed for the patient, so that they don't have to worry about that part. Now, obviously, I don't know about deductibles and so forth, and you know, the costing for that. Our office works through and works with patients so that we can offer it. But that question brings forward, you know, when people ask, is insurance covered, what they're really worried, sort of asking, obviously they're asking if insurance covers it, but you know, this is something that most patients have not heard about. It's not something that a lot of physicians even offer to their patients, including in my own profession, including in my own specialty in urology. There's more urologists that don't offer this than do. The vast majority don't. So the patient is left thinking that perhaps this is experimental, this is something new, etc. And as I said today, this has been around for a long time. It is truly verified, studied, understood, and so it is a treatment option. The other part of this, I think that's also an interesting question is when we look at costs for this, obviously a pacemaker upfront is expensive, but from the setting of from the viewpoint of a patient, when they're spending $100, $200, $500 on a drug a month, this in the long run is actually economically a more viable treatment option. So it's something that we really do owe it to society to offer.
So kind of along those notes right there, there's a question that came in. I'm currently having to use 4 to 5 pads per day. Will this eliminate or reduce my need to have to use those moving forward?
So while I'd like to say that it will eliminate, we can't always promise that, but it will drastically reduce the number of pads, typically the vast. So when we look at from a patient experience perspective, most patients will have at least 50% improvement, but the vast majority will fall in that 85% improvement. So can I make you completely continent and never have a single leakage episode? No, absolutely not. For the vast majority of our patients, they do tend to have the high-end outcome and achieve a much better state than they came with. I also, this is my chance, I guess, to brag a little bit. When we've been doing it for a long time, we get good at it. We get experience. This is a relatively simple procedure, but having done it for almost about 20 years, I will tell you, I have gotten better at it as well. I think we've really fine-tuned the procedure. We talk about it to patients and even other physicians about how we do it. And so we've gotten very good at how we do it. And I think that's very important for InterStim as well. That sometimes gets understated. That experience that you get from doing it so many times, and then offering it to patients also, knowing what the nuances are of InterStim, that experience, I think, is crucial for a good outcome. And so with the experienced physician or someone that is willing to put the time in to do a proper implant for the patient, you do end up with good outcomes.
Okay, and then the next question is actually two questions, but I'll combine them because they're kind of the same. If you've had a sling procedure or have you already tried Botox, would I be a candidate for InterStim?
Yes and yes. So that's the short answer. The long answer, the more detailed answer would be that it really depends on what what kind of incontinence it is. So if you had a sling and it failed because it did not address the stress incontinence, this is not the answer for that. So that's the thinking part of what we do. So not everybody should get an InterStim. If you present to me with stress incontinence and had a sling and then you're still incontinent, the questions that I have to understand, that I have to answer is, are you leaking because the stress incontinence didn't get addressed because of a failed sling? Are you leaking because the stress incontinence fixed the stress incontinence, but you still have overactive bladder? And so forth. With Botox, a little bit easier. If not necessarily easier. If the Botox failed because you had the wrong diagnosis and you actually had stress incontinence, then we need to talk about stress incontinence therapies. If the Botox failed because you do have overactive bladder, but it just didn't work for you, then InterStim is an option. So really the intellectual part of this exercise in truly properly defining the kind of incontinence, what's causing it, is very equally important as the therapy itself. And so it's our job to understand the whys and the whats about the incontinence and then offer the appropriate therapy.
Okay, and then I have one last question, unless anybody has one, they can type it in the Q&A. What are the physical limitations with this procedure?
For the vast majority of people, nothing. Once the patient is healed, and that usually takes somewhere between 2 and 4 weeks, they're free to do whatever they want. On the label markings, they're not supposed to go skydiving and scuba diving because of the impact of atmospheric pressure, but the vast majority of people don't go scuba diving deep enough for it to be an issue, and skydiving, well, just don't jump out of a plane.
All right, well, I think that wraps it up. There's no other questions in the Q&A. So thanks everybody for participating in this webinar. Again, Dr. Bukkapatnam's phone number is on the screen if you'd like to make an appointment. And Dr. Bukkapatnam, we thank you all very much for your time and your interest in educating the community.
My pleasure. Thank you for arranging this, and I look forward to meeting you all to further help you. Take care, everybody.
Thanks, Dr. B.